Hello, welcome everyone to another episode of Growing Stronger's A Conversations. This afternoon, we are here with Dr. Nadia Merchant from Children's National Hospital in Washington, D.C. Nadia is a pediatric endocrinologist and geneticist at Children's National. Her clinical interests include bone health and the intersection of genetics and endocrinology. She is involved in multiple multidisciplinary clinics as the endocrinologist at the Bone Health Program with Orthopedics, the Muscular Dystrophy Clinic, and the White Matter Clinic, specifically for X-linked, and I will never be able to say this word correctly, adrenoleukodystrophy.
Yeah.
Right, good. Good. I think I had to say that in our episode with Dr. White as well. And the 22Q clinic. She is passionate about maximizing a patient's potential. Dr. Merchant, thank you so much, or Nadia, thank you so much for joining us today, especially in the month of October for Dwarfism Awareness Month, as we are really trying to highlight, members within the community and everything. And so to start, can you tell us a little more about yourself that it's not already given to us by the wonderful biography on the Children's National site?
Thank you for having me today. I myself have a skeletal dysplasia, so I'm a little person. I have 𝘾𝙊𝙉𝙑𝙀𝙍𝙍 dysplasia, which is a lot rarer compared to achondroplasia, but there's a lot of different skeletal dysplasias out there. I was born and grew up in Houston, and then I was diagnosed in Houston with my skeletal dysplasia. We moved around a lot as a kid, so I lived in a couple different countries. And then I went to medical school, and then I did my residency in Ohio, and then I did my genetics fellowship because I was really interested and intrigued by just genetics and how one gene can lead to such complex conditions. And I really wanted to be there to help maximize a child's potential as the family is going through a diagnosis and the child is, and how they're trying to get around the world that's a little bit different. And then also, I decided to go into endocrine because I have a lot of interest in hormones and really how do hormones work with people who may have genetic conditions. That could be a skeletal dysplasia like achondroplasia or even acromesomelic dysplasia, but then also like other genetic conditions or cancers. And do we all go through puberty the same way? Do we all grow the same way? Do we develop thyroid disease, autoimmune conditions as such? So I've been faculty at Children's National since 2019. So that's kind of a little bit about me. So I guess so one of the things that I thought we would talk about today is really beyond the genetic condition, really, right? So we all love to, I think that a lot of us, when we have a genetic condition, we like to relate a lot of everything to our genetic condition, but we're at risk for other conditions too, right? Just like the rest of our family members maybe. So high cholesterol, diabetes, or hypertension. And so I think that was one of the things that we were both talking about earlier is like, what would be of interest? And so I thought that I talk a little bit about bone health really, and then we could go from there and answer some questions. And so I'm going to just see if I can share a few slides because I think that's helps me kind of show here. So when I think about bone health, right, we all have a certain amount of bone density that we build over the years, and majority of it gets built while we're in puberty. So we start with a certain amount of bone density, and then that kind of gradually increases as we go. And majority of increase happens during puberty, and then it still it can increase a little bit till our 20s. And then by the time we're 30, it's either we're maintaining it and then slowly, gradually it decreases. And then sometimes we have an underlying condition, which may make your bone density less. Or something or the other happens and you are on treatments for something and your bone density isn't as high. So my goal is, how do we maximize every child's potential for bone density? Because we also don't want to fracture or be affected, like we just want to reduce the fracture risk and bone pain. Because obviously, if you have a lot of bone pain, you also are not able to, okay. Can you see my chat box here? So then you can't.
No, you're good. You're good.
Okay. So I think that's something that I always think about is like, what can we do to maximize it? So from a bone health screening perspective, when you come to a bone health clinic for me, you will see if you're seeing just endocrine, or if you're seeing endocrine and orthopedics or genetics. When we're thinking about bone health, we're thinking about what is your diet? How much activity do you do? Because mechanosensors in our bones tell us to build bone. So you have to be walking in a sense to be able to build bone density. For example, swimming doesn't build bone density because your mechanosensors aren't putting weight on your bones. Are you on any medications that could affect your bone density? So for example, steroids, if you're on it for long periods of time, can definitely have a bigger impact on your bones and you won't increase. And then do we have any risk of fractures? Have you had fractures? And kids break bones while on a trampoline, for example. Is that matter versus somebody who just broke a bone while walking? And then from an endocrine hormone perspective, I always want to know, are they growing? Have they gone through puberty? How does their spine look? What's their motor function? To get an idea of like, what is their capacity, but also where are they in my expectations of their bone health? And then I may get labs to determine if they're in puberty or not, get a vitamin D and a calcium level. So we know that there are certain conditions that are linked to bone, increased risk of fractures as such. And I'm not going to go into that much in a sense specifically. I mean, OI is a completely different condition, which can be in the category of a dwarfism or little people, and it's a little bit different than a lot of the other skeletal dysplasias, but some of them are at higher risk for fractures than others. But what are threats to bone health? So how can I think about my bone health every day? Immobilization. So even just sitting on if you're just sitting all day, kind of how do we increase our activity? Try to walk a little bit, right? That helps you build your bones or maintain your bones. If you have any inflammation condition, that also affects your bones. Delayed puberty. We don't have a lot of delayed puberty in majority of kids or adults, like kids with skeletal dysplasias. And then vitamin D deficiency. So your calcium and vitamin D intake is really important through your diet. And some people just need to take vitamin D supplements because they're not in the sun enough, or they're not getting enough in their diet. And then we know that obesity and steroids can have an effect. So this is my little way of thinking about bone health. So the reality is majority of it's genetic. So we can't really change the genes that we have. So even if you have a skeletal dysplasia, you have a risk factor of bone, like just underlying osteoporosis that may be there in your 50s or 60s. But really, what is it that we can do? So vitamin D and nutrition are really important. Making sure you're taking enough milk, cheese, yogurt, or even oat milk, almond milk if you don't like if you're lactose intolerant. And then physical activity is really important. I think those are the two that are really important for us to be thinking about from bone health perspective. And a lot of us may not be as active, and I think improving that activity level can go a long way. So that's from my standpoint of bone health. But I just thought I would we can have a discussion and we can go from there on what questions are. But that's my focus is bone health from that standpoint.
Yeah, and that was so you were great because I completely forgot to explain at the start of this episode that our focus for today that we want to discuss is kind of beyond skeletal dysplasia, because I do think, and I know we kind of talked about this a few weeks ago, how those who aren't in general familiar with dwarfism or skeletal dysplasia, bone dysplasia, I think all think that if they see someone with a skeletal dysplasia and then they see someone else with a skeletal dysplasia, they may think like, oh, like they probably all grow the same and have kind of their bodies develop and grow the same, since they both have bone dysplasia or skeletal dysplasia. And I think it's what we wanted to talk about was how, just like people who don't have bone dysplasia, and I'll just keep on referring to bone dysplasia or skeletal dysplasia, since that's kind of covers it all. But I think people think everyone with skeletal dysplasias goes through puberty or growth the same as anybody else with skeletal dysplasia, but we're honestly, just like anyone who does not have, I guess, skeletal dysplasia, and we still, go through puberty when we go through it. It's not like, I think I'm trying to say that correctly. Like, it's not just, I went through puberty in the same sense my sister, who does not have skeletal dysplasia, did. Like, my having, I guess, achondroplasia specifically did not impact, when I started, or I guess when I went through puberty. And I think, that's something people always just have, or, those who aren't just informed kind of have that misconception. And so, like those without skeletal dysplasia, we, like, our bodies still go through, the different changes the same way, basically, but just we also have our dysplasia on top of it.
Also, like, the other way to think about it is that there is known that people can go through puberty at different ages, and it runs in families. So there are early bloomers and late bloomers. So if you went through puberty early, if mom and dad went through puberty relatively early, then there's a likelihood that the child will also, with the skeletal dysplasia, go through puberty early, or maybe a late bloomer because they were all also on late bloomers. So I think that, but I always say that just because you have a skeletal dysplasia doesn't mean you're at risk for having other conditions. So polycystic ovarian syndrome, which is 1 in 8 to 10 females has it, you could still have that, right? And it's not related to your skeletal dysplasia. It's just something you could have irregular periods because you have irregular periods, and it may run in your family. So I think it's always important that when you're, that you get evaluated appropriately for whatever you have, but not only the lens, I would say, of the skeletal dysplasia, because oftentimes you're seeing a provider who may have never seen, with rare diseases especially, you could see a doctor who may never have seen anybody with you with the condition you have.
I remember, not really related in terms of growth, or maybe it was, but I remember, I forgot like what specifically the situation was, but I know in like I think it was 4th or 5th grade, something like, there was something in school, and I either said I couldn't do whatever, I think it may have been for a field trip or something, I don't know, or like a food, it may have even been like a food thing, and my teacher thought, just kind of like assumed like, oh, it's because Chandler has achondroplasia, she can't do. And really it was more, I think it was just like a preference of mine, or like it was kind of something like I could see where it would be like speculated it was from me having achondroplasia, but really it was like not related to my having achondroplasia at all. It was like, I think something totally, either another like medical thing I had, or whatever. But I was like, but I just remember thinking like, it's not like achondroplasia, it's not the reason why I can't do this. It's like, but it's just, it's funny that people kind of just always assume it always comes down to our dysplasia and not other health conditions that we may have. Because in my own family, I have both sides for my parents, risks of diabetes, heart disease, huge risk for heart disease, which I know people on the shorter side in general are at higher risk. And so my mom's always like, oh, you have a double whammy. And like, she still talks, or she still comes with me to doctor's appointments. And that's like always one of the first things that she says. And she's like, well, she also has, the family history, but she also has skeletal dysplasia. And so that's kind of, makes her a bit more at risk. And so it's just, we all have, even though we all have skeletal dysplasia, we also have our own, sometimes we can have additional health issues unrelated. And so
I mean, like,
I don't
there's
know why it took me
20,000
so long to say that.
we get 20,000 genes, right?
Yes.
And they all have a little bit of a contributing factor. And then we have environmental factors that may also play into and have a factor on what we may develop as health conditions. So I think that's a lot. It's really important to think about that, and also make sure that in some ways you are able to advocate for yourself and know about your condition, and also get the appropriate workup and be able, because you may be guiding, especially when you go into the adult world, you may be guiding your provider, the doctor you're taking care of, who's taking care of you, on like, yes, I have the skeletal dysplasia, this may be what I need, but then I need to be worked up appropriately for everything else. And that's really important to know.
Is there any advice you would, and I kind of want to ask this, I guess, in two different ways, any advice you would give parents of a child with any skeletal dysplasia, bone dysplasia, who, you know, definitely feels like maybe their child has another health, you know, factor that's that they're dealing with, but their, you know, provider keeps on just saying, or their main provider says, oh, well, it's because of their skeletal dysplasia. Like, any advice you would give to them to, I guess, continue to be proactive and advocate for, like, no, I want to, like, you know, get to the bottom of this. And then basically the same exact question, but more so for, let's say, you know, someone like me who I'm pushing 29. And so, you know, I've been able, you know, I talk about for myself in doctor's appointments, but still have those moments where I'm like, I kind of want my mom to speak for me, and I'm shy, but like, you know, I think as we enter the adult world, sometimes, you know, we're like, don't know if someone will believe us when we feel like, you know, when you're kind of there on your own and finally advocating for your own self in an appointment. And so, you know, what advice would you give for someone, an adult with skeletal dysplasia, who feels like they've got a health concern, but everyone's telling them, oh, it's because you have skeletal dysplasia?
So I think that it's important so I like to transition when I'm talking to my 15, 16, 17-year-olds, or even 12, 13-year-olds that are a little more mature. In a sense, I like them to verbalize understanding of their condition, right? So what condition do you have? What do you know what it's caused by? Do you know what the risk factors are? And so that way they understand, because then when they're 18, they can advocate for themselves. They may bring a parent with them, but they can also learn to speak for themselves. So I like to do a lot of my visits for my adolescents, like with them being in charge and asking for help, because I think also a mental health component is super important, right? Like, a lot of us go through ups and downs. There's bullying at schools. There is, you know, life things that happen. COVID happened, the pandemic happened. Like, I mean, people have had to deal with some interesting, challenging situations, right? And it's not like it gets easier as you become an adult. You could lose a job, you could, right, lose a parent. And I think that it's really important to learn to speak for yourself. So in some ways, sometimes I had to kick the parents out, because I think that one of the things is parents are really good about advocating for their child, but if their child needs to learn how to advocate for themselves. So when I have if I have parents who speak too much, I'll be like, okay, I'm gonna have you step out for a little bit, and I'm gonna talk to your child on your own. And so I think that's really important. So as that transition happens, so you learn to ask the right questions. The difficulty, I'd say, with healthcare is like, everybody has limited time, right? And so when you're in pediatrics and you're seeing, for example, a geneticist, your appointments are longer. You go in the adult world, they have like 10 minutes. They have 40 patients scheduled possibly. And they may only deal with one problem. And I always tell the kids, I'm like, when you become an adult and you go to your adult doctor, they may only be able to deal with your one issue. So you may have to schedule another follow-up for another concern you have, because you can't solve all the problems at once. And so, but obviously we are all short on time and we can't go to multiple doctor's appointments. So I think that it is important to also understand on the other side, like, there's a lot of healthcare work. I mean, right now the hospital in DC and in Baltimore, where you are, they're so full. There's like no beds available, right? Like, so even if you go for care, like, we just don't have enough healthcare providers to take care of patients. So I think that, and that definitely affects those with rare diseases that have things that are more chronic and not acute. And so I think when situations where we get really busy, the acute stuff get dealt with. And why I'd advocate for bone health is because it's not acute, it happens every day. So do we take 3 servings of high calcium foods like milk, cheese, yogurt, oat milk, almond milk, orange juice that has some calcium in it? Do we take vitamin D or multivitamin or anything like that if we're not getting enough to build the bone density that we should have, and hope that will help us? Are we staying active? Are we exercising as much as we can to our capacity, listening to our bodies, right? So don't overdo it, but also stay active. And I think those are things that I say you have to like know and learn over time and get good habits, because and then the other thing is, like, I don't know if a lot of us know how many calories we should eat a day, right? Like, what is a good weight for somebody with a skeletal dysplasia? With achondroplasia, we have a little bit of growth charts that are available that kind of help. But even that, the numbers are so small, right? It's not like in like the CDC where you have a lot of population to follow. So I think there's all these different things to think about, which makes it a lot more challenging.
I know, growing up, the like achondroplasia growth chart was something I would say my mom like just referred to religiously for me, because I always fell on the smaller side of it, like on the bottom of the chart. And so, every time I had any sort of appointment, we would, I was always, slightly off. And I remember there was one time when I was getting close to that puberty age, and she was just concerned because, obviously those with achondroplasia specifically, sometimes if they are, I would say, we go back to talking kind of about, what's the good like weight to height ratio for someone with achondroplasia. And my mom, since I was on the smaller side, I was, 310 at age 14, I would say. And I was, I would say heavy. And so it's not that I was heavy, but it was clearly impacting my spine. And so we were concerned about that, or, we were concerned it was going to start really impacting my spine. And my mom mentioned it to like a primary care doctor or a pediatrician, who instantly just kind of was not familiar with skeletal dysplasia and thought, oh, this girl's mother is like trying to just, body dysmorphia, whatever. And my mom's like, that's not it at all. Like, she has skeletal dysplasia. Her bone, or her like skin to muscle ratio with her bones and everything is not like the same as it was for her sister. So she's not going to be like, her body mass and everything to her bones, it's not going, or it's not measured the same as her friends who don't have achondroplasia. Like, it's very different. And so but it is I think, especially being at that age, can sometimes be a sensitive thing to talk about. But I think it's also is very important in terms of health, because we have to be cautious of that and everything.
Yes, I think, and also I think that one of the things with weight specifically is I don't like to analyze weight. I always feel like,
I know, I hate talk, like, I don't like talking about it, but it's like,
but I also think it's about being healthy lifestyle, and
exactly.
And then so I think that that's really important. That, like, I always try to say healthy lifestyle, and also making sure kids are eating healthy, and kind of thinking about, like, the American diet's very high in calories. I mean, you eat out and it's like 1,000 calories on a dish, right? And so I think that we need to think about eating healthier, less snacking in general population. I mean, I think we had like 160% increase of type 2 diabetes in children at like our hospital during the pandemic, because kids had gained weight. And so that doesn't only apply for achondroplasia, it applies for everybody, right?
Yeah.
And so I think that is what I always say is, like, we all need to be active, right? And so staying active and eating healthy is really important. But also, somebody may think that the parent may, or the child, they're already dealing with enough. We don't want to have to talk about their weight, right? And so, because it can be a very sensitive topic. And so that's one of those things where I'd say, like, it's important that we think about a healthy lifestyle and healthy eating habits, And that starts really early. And I always say, who buys the groceries? The parents. What's in the house? Who kind of decides what the kids eat? It's a lot of the time it's the parents. And so I'm like,
Mhm.
you have a lot, like, yes, your kid may be picky, but parents do have a lot of a role, especially in the younger kids, on how the child eats, the portions, what types of food. Is it fried food or baked food? Are we doing home meals, or are we doing and I mean, it is hard sometimes to make all home cooked meals, and outside food is really good. Restaurants are like a lot of good restaurants these days. But I think that that's one of the other things that I feel like when I was growing up, even I don't remember my doctor ever telling me that, like, oh, I'm over, like, I overweight, or I should have
Right.
be more active. And there is that fine line where I think that a lot of people are like, don't want to even bring it up unless they have diabetes or high cholesterol.
Mhm.
They're just like, ah, whatever, they're fine. And I don't know if we really have exact parameters for us to guide, which also makes it a little bit more difficult. So
Right. Right. One thing I had made a note of, and kind of out of interest, and just since it's about, skeletal dysplasia in general, at the bone health clinic, obviously right now we're kind of in this time of, there's a lot of achondroplasia and skeletal dysplasia research going on in terms of possible or available, soon to be available, currently available, possibly in the future available treatment options. Does the or I guess your clinic or the bone health clinic, you know, see patients or provide any sort of or involved in any of the new skeletal dysplasia research studies and treatments going on? If so, what's that kind of like? And can you tell us about it?
so I mean, I guess, like, there's a lot of new drug treatments, and I think it'll be interesting to see how much they help. My interest is really not just the height, really. I think the height's an easy way to measure the parameters of whether the drug
Yes.
is even helping, because it's a very fixed number that you can follow. But really, are we going to decrease the complication rate, right? Are we going to decrease just like the spinal stenosis that happens in achondroplasia? Are we going to decrease the foramen magnum stenosis if we start the drug earlier for achondroplasia, right? Are we going to decrease the amount of back pain adults have later on in life if they were treated as a child? But that's the only data we're going to find out 20 years later when people report it, and that's what makes it a lot more difficult, right? So the drugs are getting approved because of rare disease drugs. It works a whole different way, but really because of if it improves the growth, because you can't get a high enough statistical number to show that, to be able to say, oh yes, it's significantly improved. Like I would say, like the COVID vaccine, we had high enough numbers that things could move much faster because the general population was getting vaccinated. So for rare disease drugs, it's a little bit different. So I mean, so Bone Health Clinic is specifically really my clinic that I work with orthopedics with, is really for those kids who fracture, have bone pain, or have low bone mineral density, or vitamin D deficiency, or high. And I have a calcium clinic, so that's specifically for that. I do see kids with skeletal dysplasias who have like low bone mineral density or other related issues, or poor growth for other factors. There are studies going on at this time for like trying drugs that are for achondroplasia in other conditions too. So, but that's more on a research perspective, and I think only time will tell us. It's a very exciting time, I think, for us to see what rare disease drugs do and how they work. It's been, I mean, some of the conditions that I take care of, like some of the muscular dystrophy conditions, the life has changed, like the whole prognosis has changed because of some of the treatments. So I think just the same, I would say, is really, we're really following. It's going to be interesting to see. And I don't think it's for everybody. I always say, you don't have to be part of a study. You don't have to decide to do treatment. People have been living with achondroplasia for many, many years, and they've been fine. So it's only, I think, a personal decision based on the family and the child to decide if they want to be on a treatment or not.
Mm-hmm. Great. Since while we're here, I want to ask for our attendees who are on, if you have a question for Dr. Merchant, please feel free to submit in the comment box or Q&A box. Again, we're talking about kind of just beyond skeletal dysplasia, bone growth, bone health, and everything like that. Let me go back to, hang on where it was, just to like see if I can come up with more questions if our live audience doesn't have any. Hang on one second. Where was I? There we go. All right. I guess one thing I do have that might be a good question, because I know it's one that I've kind of just gotten from people in general before, but what is from, I guess, the geneticist and endocrinologist in you, can you even though we're talking, about skeletal dysplasia in general, a lot of people I know have asked me before, like, why does or why do people with achondroplasia not see or typically go see an endocrinologist? I think, they don't realize how, the different growth, and everything like that. So what's the difference between or like what makes somebody with skeletal dysplasia see an endocrinologist, and like what conditions don't see an endocrinologist? Did I say that correctly?
Yes.
Did I ask that correctly?
So in general, endocrinologists do all kinds of things, anything hormone related. So if you develop type 1 diabetes, you'll be seeing an endocrinologist, right? Thyroid disease, same way. You can get diagnosed at birth, or you can diagnose later on in life. From a growth specific perspective, right? I always say that if you're followed on a growth chart, right, you should be still growing until you finish puberty. So if you stop growing and you're not done growing, then you probably need to be seen by somebody like GI or endocrine to figure out why is it that you're not growing at all. Like, because you could develop celiac disease, or you could develop some other like condition, right, that could be affecting your growth. So that's when I have those kids where like they have a skeletal dysplasia and they stop growing, and then they get diagnosed with celiac, right? Like gluten allergy. So they can't eat bread anymore. So those are ways that you may get referred. Or for example, if you're 13 as a girl and you haven't started puberty, or 14 as a boy, then you would need to come in and get evaluated. And so those are reasons too. Now, growth hormone has been around for a long time, and there's this thought that, oh, if I'm on growth hormone, I'll be taller. Growth hormone doesn't work on even average height people, right? Like to be taller. It works on those who have growth hormone deficiency or insufficiency. If everybody could be taller with growth hormone, everybody would be on growth hormone. And there's risks and side effects.
I'm glad you're saying this, because like I've had so many just conversations in the past, and I've seen other people explain to other people, like, growth hormone, it's not like, it doesn't do anything for achondroplasia at all, because achondroplasia is not a growth hormone disorder. And so people just, I think they focus on the word growth, and like, they hear growth therapy, and so they're like, oh, everybody can have growth therapy. And like, no.
Yeah. So I think that's the reason. So somebody would come in because of that reason. So I think that's where I would say that's why they'd come in if something wasn't going well. So if you fell off the growth chart, you weren't growing, that's when you would come to an endocrinologist. You might be losing weight, that maybe bring you into the endocrinologist. But generally, I mean, some of the new treatments are being done by endocrine. So you may come to an endocrinologist for if somebody decides to go on one of the newer drugs.
Right.
But otherwise, a lot of the time, genetics, like kids with skeletal dysplasia, they're not seeing an endocrinologist.
Right. Well, unless our audience has any questions, that was kind of it from my end. Is there anything maybe that we didn't discuss that you would like to share, or any additional guidance or information you can provide? If not, thank you so much for joining us. But
I think the main thing I would say is take care of your health. Like, if you, and always think about the overall like overarching, like just like how you should take care of your health for the long run, and your mental health, and everything else, and thinking about all of that. in the
Great.
combination. But thank you
I
for
like
having
that.
me.
Thank you so much for joining
And
us.
enjoy your Friday evening.
You too. Awesome. Thank you so much.
Bye.
Bye.